Hey, NICU champions! Have you ever cared for a preemie who just can't seem to wean off oxygen or ventilation even weeks after birth? That's often the case with bronchopulmonary dysplasia or BPD, a chronic lung disease that's become one of the most common complications of premature birth. Today we're diving into what causes BPD, what it looks like in the NICU, and how nurses support these fragile lungs toward growth and recovery. Bronchopulmonary dysplasia is a chronic lung condition most often seen in preterm infants who required prolonged respiratory support. It develops when immature lungs are exposed to high oxygen levels or mechanical ventilation, leading to inflammation, scarring, and disrupted alveolar development. BPD typically affects infants born before 28 weeks or with very low birth weight, less than 1,500 grams. Signs and symptoms of BPD include persistent need for oxygen beyond 28 days of life, difficulty weaning from CPAP or ventilator, tachypnea and increased work of breathing, crackles or wheezing on auscultation, poor feeding due to respiratory fatigue, recurrent respiratory infections. BPD is a clinical diagnosis based on prematurity plus oxygen dependence beyond 28 days, chest x-ray showing hyperinflation, atelectasis, or fibrosis. Rule out congenital heart disease or other lung malformations. Severity is classified as mild, moderate, or severe, depending on oxygen needs at 36 weeks post-menstrual age. Medical management include respiratory support, nasal cannula, CPAP or ventilator if needed, gentle ventilation strategies to prevent further damage, medications, bronchodilators for airway support, diuretics to reduce pulmonary edema, corticosteroids in select cases, nutrition support, higher caloric needs to support lung growth, may require NG or G-tube feeding. Infection prevention is crucial. RSV prophylaxis and immunizations on schedule. Nursing care include respiratory monitoring, observe for apnea, desaturation, or increased work of breathing. Monitor pulse oximetry and adjust oxygen carefully. Avoid both hypoxia and hyperoxia. Assess breath sounds and chest wall movement with every shift. Feeding and growth support, monitor weight gain and caloric intake. Coordinate care during feeds to avoid fatigue or desats. Collaborate with dietitians and speech therapists. Family education and discharge planning. Teach oxygen safety and home monitor use. Provide clear guidance on signs of respiratory distress. Coordinate follow-up with pulmonology and developmental teams. BPD may not resolve overnight, but with thoughtful, consistent nursing care, these babies grow stronger day by day. As NICU nurses, we don't just monitor, we advocate, educate, and walk families through every breath. What's your best practice for supporting infants with BPD? Share below, like, subscribe, and follow for more respiratory-focused NICU care because every breath is a milestone.